Muted.
Welcome to the April 23rd ICHP COVID-19 update. My name is Scott Meyers, and I'm the Executive Director of the ICHP, Illinois Council of Health System Pharmacists, and your moderator for tonight's update. So let's get right to it with our first two speakers, Dr. Justin Moore and Dr. Anooj Shah, both PGY2 infectious disease residents at Northwestern Medicine and Midwestern University Chicago College of Pharmacy. They're going to provide you with a brief overview of the treatment of the coronavirus.
Thank you very much, Scott, and thank you to ICHP for putting this together, as well as all of you for joining us tonight. We've been trying as best we can to stay up to date on all things COVID-19, and it seems like new information pretty much comes out hourly, so this may be outdated by tomorrow, but I'm happy to share some of the information with you all tonight. So here are tonight's objectives, pretty straightforward, so I'll give you a second to read those. And just a little background, as I'm sure you're familiar, we'll be talking about the virus SARS-CoV-2, which is a member of the coronavirus family, the 7 of which to infect humans, and the disease itself is COVID-19. I'm sure that's a word that you've heard probably a million times in the last month or so you're going to hear it a few more times throughout the discussion. As far as the etiology, the first cases popped up as a cluster in China in late 2019. With patients having pneumonia due to an unidentified pathogen. It was later discovered to be a virus with about an 88% nucleotide similarity to a SARS-like coronavirus that was found in bats. This was then connected to a wholesale animal market in Wuhan, and the rest is kind of history from there. It's transmitted via respiratory droplet, as well as possibly via aerosol in certain procedures such as bronchoscopy. In addition to fomite oral contact, meaning that the virus can live on inanimate objects and then be transmitted by contact to one's face or mouth. The incubation period in which the patients contract the virus and then actually show symptoms has been reported to be up to 14 days, with the median duration around 5 to 7 days. This can occur in asymptomatic patients as well, or asymptomatic individuals as well, which supports the need for like widespread testing, such as what was performed in South Korea. So viral shedding has been reported to occur for around 20 days, with reports as long as 37 days in severe disease. And as you can see here regarding the pathophysiology, so the coronavirus S protein or spike allows for viral entry into the host cells via serine protease. And then the envelope spike binds to ACE2 receptors, which again, I'm sure you're kind of familiar with at this point, that are commonly found in the lung, cardiac tissue, GI tract, as well as the vasculature. So as pharmacists, let's get into kind of what we do best, discussing potential medication therapies. So to date, just a disclaimer, no therapy has been found to be effective against COVID-19, and all of the agents we'll go into are still under investigation. So just keep that in mind as we discuss all of these. While we may use the term evidence, we're using that loosely. So these are the agents we'll be highlighting. There are obviously a ton of others that are being investigated, but more information to come on those. And here you can see the proposed mechanism of each of the therapeutic options, whether that occurs at cell fusion or entry, such as hydroxychloroquine or chloroquine within the viral replication process, such as lopinavir or remdesivir. Or as inhibitors of excessive inflammatory response, such as the IL-6 inhibitors, which include tocilizumab and sarilumab. So we're going to talk about all of those tonight. The first that we'll be discussing is lopinavir, ritonavir, or Kaletra, which is a protease inhibitor with activity against the 3-CL protease enzyme that again prevents that RNA replication. This agent actually has the strongest level of evidence, albeit negative. But this came in the form of a randomized controlled trial of about 200 patients that were severely ill in the hospital. They compared lopinavir, ritonavir with standard of care versus standard of care alone for 14 days. Just of note, the median time from symptom onset to randomization was about 13 days. So you're looking at 2 weeks before patients actually received treatment. And they demonstrated that the time to clinical improvement or live hospital discharge was not significantly different among the two groups, so about 16 days for each of them, which you can see depicted in this top graph here. Lopinavir ritonavir was also more frequently associated with some GI-related adverse events and was actually stopped early in about 13% of patients due to those adverse events. I doubt that you're seeing a lot of these used in your setting, especially in the Chicago area. I think most people across the city and the country have kind of fallen out of favor of using Kaletra. But in case you are, you do want to watch out for CYP450 drug interactions. So there is a really good resource, which is here. It's provided by the University of Liverpool. They have a COVID-specific drug interaction checker. It has an extensive list of potential interactions, so definitely check this out. It's a good resource to know. Next, we'll discuss hydroxychloroquine, the most highly publicized agent, I guess. But it's an anti-malarial that is believed to reduce the binding efficiency between ACE2 on the host cell and then that spike protein on the virus, as well as possibly having anti-inflammatory and then immunomodulatory properties that may inhibit release of inflammatory cytokines, which I believe Craig will get into in a bit. The various dosing schemes were kind of in the initial controversy, but things escalated from there, as we'll talk about. You can see here the dose that we were recommending at Northwestern. We're not really using it much anymore, but we'll discuss that a little bit later. And then just to know why this came about. So it initially demonstrated some in vitro activity that was 5 times more potent than chloroquine for SARS-CoV-2. So that was the initial response that kind of motivated people to study this, as well as remdesivir was kind of launched in the same study. For patients receiving this, we should monitor QT prolongation because it can put these patients at higher risk for arrhythmia, particularly those with any baseline cardiovascular disease or acute renal failure, which we'll also talk about later in the presentation in just a bit. So there have been a lot of anecdotal reports related to hydroxychloroquine, and most of them are in the preprint phase awaiting peer review. So I just wanted to mention a few of the major pieces of information. So on the left, we have a report from China that describes a randomized parallel group trial to evaluate the efficacy of hydroxychloroquine. They studied it at a dose of 200 milligrams BID for 5 days versus supportive care or standard of care in 62 patients with mild COVID. Note they did exclude severely ill patients. And they found a shorter fever recovery time as well as duration of cough by about a day in those given hydroxychloroquine. The authors also noted improved chest CTs in the treatment group with mild ADR in those treated with hydroxychloroquine. Next, in the middle here, we have the infamous French paper from Gautret and colleagues who looked to evaluate virologic clearance at day 6 among 42 patients, 26 of which received hydroxychloroquine, and 10 of which, kind of pointing at issues with the method and study design, were not treated at the same facility, but they just happened to not receive hydroxychloroquine, so they thought they'd be good controls. And then also, just of note, 6 patients who received hydroxychloroquine were excluded, as the author stated that they were lost to, quote, lost to follow-up, when in actuality, 3 of the patients were transferred to the ICU, 1 patient died, 1 patient left the hospital, and then 1 patient withdrew from therapy due to adverse events. So kind of, again, flawed method. They also reported an additional 6 patients who received hydroxychloroquine in combination with azithromycin. Azithromycin in this case was likely for a presumed bacterial cap. And they reported improvements in virologic clearance amongst those receiving hydroxychloroquine, and then an even greater virologic clearance in those receiving the combination of hydroxychloroquine and azithromycin. So thus kind of the legend was born at that point. But due to these major flaws, which we discussed in their methods and then inconsistencies in their reporting, most researchers and clinicians are now kind of discounting these findings. And then on the right, so regarding safety, I just wanted to mention this retrospective review from NYU that found among 84 patients treated with hydroxychloroquine and azithro, combination therapy was actually linked to significantly associated QT prolongation, with 30% of the patients with a QT increase of greater than 40 milliseconds and 11% of patients with severe prolongation above 500. As I mentioned, the acute renal failure was noted to be a predictor of this severe QT prolongation. So just keep that in mind if you are recommending it for these patients. It's probably something that we should be checking at least at baseline and then maybe throughout therapy. So in response to the publication by Gautret, and then the press conference, which you can see here from the US president, you can see a spike thereafter, which is associated with this demand for these agents, which subsequently caused drug shortages, which Tony will discuss later. But we have also seen shortages for other agents, so other pneumonia drugs, such as azithromycin, largely tied to this study. However, there have been really no conclusive pieces of evidence to support a benefit with hydroxychloroquine compared to supportive care. So many clinicians at our institution are no longer recommending this for hospitalized patients and are more so favoring shunting these people towards clinical trials, which is also supported by national and international guidelines from IDSA, as well as the NIH. So I just wanted to kind of take a step back and highlight the power of social media. I know it's maybe not portrayed in the best light all the time, but there are real benefits to it, as well as the academic discussion that's kind of happening on Twitter right now. Yes, the cat videos are nice too, but I think that it really is finding its time now. But we all want to find what works for these patients. We all want to treat COVID and do so quickly. But we have to continually critique this evidence. People's lives really depend on it. I probably sound hypercritical, with the Gautret paper, and I'm sure the authors are hoping their findings help people. But I just want to stress how important it is for all of us to maintain a critical eye when reading these studies, because, despite what many have said, there is real harm with some of these agents. In response to all of the criticism, the journal actually stated that the publication does not meet the expected ethical standard and it will undergo a more thorough peer review. However, it is still in print today. So I think as pharmacists, it's our job to kind of synthesize this literature. Again, it's coming in super quickly and, every day it's kind of an onslaught of new information, but we need to do our best to try and understand it and apply it to our patients and then dispel a lot of the misinformation that is out there. Because obviously we need to have science supporting these recommendations. And so Anooj will actually talk about that going forward with some of our next agents. I think Anooj might be having some issues with some audio here, but we did just want to point out some of the IL-6 inhibitors, so tocilizumab or Actemra, as well as sarilumab or Kevzara. The doses are listed here. In most cases, it's going to be a one-time dose. You can repeat those doses anywhere from 8 to 24 hours later. So the evidence for tocilizumab surrounds an observational study done out of Wuhan that looked at critically ill patients. They compared tocilizumab to standard of care alone, tocilizumab in combination with standard of care. And they found that tocilizumab improved oxygen requirements in all 21 patients. Fever improved in about 16 patients, and opacities present on imaging also improved in a majority of patients. We do want to look out for some hepatotoxicity as well as secondary infections, as we know this reduces the immune response. And then gastric perforations have also been reported. There's also a French paper that came out recently that has similar findings to what was produced from this group out of Wuhan. And that's inspired a lot of clinical trials around the country and the world. So I know University of Chicago is enrolled in one of the studies for tocilizumab in severe disease, and I think also in mild disease. And then we at Northwestern are involved in a sarilumab trial in some of our more critically ill patients. And so we want to make sure we're looking at some of the same adverse events there. Of note, sarilumab was found to be more potent in vitro, so that's why we're using it in clinical trials. Remdesivir, so this is an antiviral with activity against Ebola, MERS, coronavirus, SARS-CoV-1, as well as SARS-CoV-2. This is a nucleotide analog of adenosine triphosphate that causes some chain termination in the viral RNA. You can see the dosing listed here, and some of the monitoring that you want to look at are hepatotoxicity as well as GI toxicity. So this recently was reported in the New England Journal of Medicine. an open label report of about 61 patients who received remdesivir via compassionate use, showed improvements in oxygenation in about 70% of patients, which you can see in the table on the right, as well as an overall 28-day clinical improvement of 84%. But take that with a grain of salt, given that we don't have any comparator here. And there was a lay press report that was leaked today saying that remdesivir actually showed no benefit in COVID. So I think the jury's still out and we need more hard evidence in randomized controlled trials, which we should be obtaining pretty soon. So we're part of the NIH remdesivir trial. And so we are hoping to get that information in the next weeks to months. Lastly, just want to talk about convalescent plasma. So this obviously is adaptive immune system as exposed to the virus and then creates specific antibodies to aid in clearance of that infection. So we're obtaining virus antibodies from recovered donors, which you can see in the diagram in the bottom. It was previously used in an array of viral infections. There have been 3 or 4 case reports now of about 5 to 10 patients, one in JAMA, one in Lancet ID, I believe. And they showed some improvement in clinical symptoms as well as oxygenation, improvement in chest CT imaging, as well as inflammatory biomarkers such as CRP and IL-6, and then some reduction in the viral load. So there may be some kind of hope for convalescent plasma, but again, I think the jury's still out and we're going to need more kind of trials and more evidence to support its widespread use. And lastly, I just wanted to mention a few other agents. So anakinra, canakinumab are IL-1 inhibitors, as well as JAK inhibitors, baricitinib, and then reluximab, and then eculizumab is a complement inhibitor. So these are agents that are starting to pop up more in reports of use as well as clinical trials. There's some talks that baricitinib may be part of an adaptive trial. So I think as time goes on, we're going to see more and more of these agents. I know there's information about vitamin C and colchicine. So all of these trials or agents that you would think really have no utility are being explored, and they're doing so in clinical trials. So I think as time goes on, we're just going to get more information, and buckle up. Thank you.
Thank you, Justin, and sorry, Anooj, for the technical difficulties. We apologize for that, knowing that you prepared for this. Our next speaker is Dr. Craig Cooper, critical care specialist at Northwestern Memorial Hospital and faculty member at Roosevelt University College of Pharmacy. Dr. Cooper is going to provide an overview of cytokine storm and how it's being effectively treated, which is frequently seen in patients with severe coronavirus. Dr. Cooper, let me give you the control.
Good evening, everyone. I'm going to be talking on the cytokine storm that we see on patients who typically do really poorly in the ICU. Part of that reason is the cytokine storm that's produced. So what is a cytokine storm? First, let's look at what are cytokines. And these are small proteins released by certain cells in the body with a specific effect on the interaction and communication between cells, including those of the immune system, where they coordinate the body's response to an infection and help trigger this inflammatory response that we see in patients with cytokine storm. So a cytokine storm is a severe immune reaction due to the excessive rapid release of cytokines into the blood. This is also sometimes referred to as hypercytokinemia. And we see this commonly in, or it's most commonly seen in autoimmune disease, some severe infections, as well as status post immunotherapy such as CAR T therapy. And here you see some of the COVID-induced pro-inflammatory cytokines and markers, most notably interleukin-6, ferritin, C-reactive protein, and tissue necrosis factor alpha. Now, Ruan et al. Looked at 150 patients from Wuhan, China, and they tried to predict what were some of the factors that actually precipitated the cytokine storm and caused these patients to actually expire when they had COVID-19. And what they found was that patients with certain inflammatory markers, most notably C-reactive protein and interleukin-6, especially elevated, significantly elevated markers of C-reactive protein and interleukin-6, these patients did significantly worse than patients who did not have significantly elevated C-reactive protein and interleukin-6. They also found that cardiac troponin and myoglobin, when those values were significantly elevated, as well as the inflammatory markers, those patients did significantly worse than patients who did not have that significant elevation. Here you can see on the left-hand side a patient who is not infected with COVID-19. The pulmonary epithelium is intact, the macrophages are not in the alveolar space, and CD4 and CD8 T cells are freely circulating in their normal amounts in circulation. When we look at an individual who has moderate COVID-19, the SARS-CoV-2 virus binds to that pulmonary epithelium. Pattern recognition receptors of the immune cells recognize the virus and triggers the release of pro-inflammatory cytokines such as interferon gamma, tumor necrosis factor, and interleukins. The macrophages are the main cells that are recruited to the alveolar space and in response to this viral infection. Interferon gamma activates macrophages and produces tissue necrosis alpha, interleukin-6, and interleukin-10. The macrophages then increase the cytokine production and attract additional immune cells to the affected area, such as T helper cells, CD4 and CD8, which work to combat the virus. So we have less CD4 and CD8 in the circulation and more in the alveolar space. Normally, the immune response pathway will shut down here once the virus is cleared. However, in severe COVID-19 patients, that's not what actually occurs. So in patients experiencing a cytokine storm, this process doesn't stop as it usually would, and instead it intensifies. The cytokines attract more immune cells, including white blood cells, which in turn produce more cytokines, resulting in a weakened blood vessel. That weakened blood vessel allows fluid to seep in, filling the lung cavities, leading to the respiratory failure we see with these patients, and eventually leading to the ARDS that are seen with SARS and COVID-2. This intensifies the vicious cycle of the inflammation, which leads to damage to the lung cells and ultimately to the multi-organ failure that we're seeing in some of these patients. So this is a vicious cycle that we're trying to stop, that if we can't stop, oftentimes will lead to those patients dying. So what are we trying to do to actually cease this vicious cycle? First, it's important to understand what's actually occurring here. Interleukin-6 binds with the interleukin-6 receptor, and this forms a complex with glycoprotein 130. Glycoprotein 130 is a receptor subunit that's involved in intracellular signaling that helps regulate numerous biological processes, including hematopoiesis, immune responses, and inflammation. So when we give drugs like tocilizumab and sarilumab, they bind to the membrane-bound and soluble forms of interleukin-6. They competitively inhibit interleukin-6 from binding to the interleukin-6 receptor, thereby preventing the interleukin-6 glycoprotein 130 complex, thus inhibiting the signal transduction from glycoprotein 130 and the cause of this inflammation. So it's important to understand that by itself, glycoprotein 130 has virtually no affinity for interleukin-6. But when it forms that complex, that interleukin-6 receptor, interleukin-6 glycoprotein 130 complex, then the affinity is very high. So without that binding of interleukin-6 to that receptor, glycoprotein 130 can't cause that transduction. So if we can block that interleukin-6 receptor, that's going to help prevent that transduction and help prevent the massive inflammatory response that we see in these patients. And how do we do that? We have certain drugs that are interleukin-6 receptor antagonists like tocilizumab and sarilumab. So they're going to, if you look back at the last slide, they're going to block that receptor, as well as they will bind the soluble forms that are not bound to the receptor. So we get kind of a double whammy in that they do two things: blocking the receptor and binding that soluble form that's still out there. So these are interleukin-6 receptor antagonists. Tocilizumab is generally dosed at 4 to 8 milligrams per kilo to a maximum of 800 milligrams as a one-time dose. The common dose that's used in the studies that tocilizumab is being used at, and what we've used frequently in our ICU at Northwestern, is to give 400 milligrams as a one-time dose, evaluate their lab values, and then repeat that dose at about 12 hours, or at least 12 hours up to 24 hours, depending on the response. Now, we are going to hold therapy if our ALT and AST is 5 times the upper limit, an ANC below 500, or a platelet count below 50,000. That doesn't completely exclude the use of these agents. So if those values recover, we can go ahead and give the drug and hopefully get a response and block that cascade. So what are some of the inclusion criteria for the use of tocilizumab? First of all, you don't want to give this drug to just any patient that comes into the hospital that has some slightly elevated inflammatory markers. These patients should be in the ICU, so ICU admission should be part of your criteria. Markedly elevated inflammatory markers, most notably ferritin, C-reactive protein, and D-dimer. Not a lot of institutions are routinely drawing interleukin-6 lab values, so the use of ferritin, C-reactive protein, and interleukin-6 are some of the best, or excuse me, D-dimer are some of the best markers to use when you're thinking about whether you're going to give an interleukin-6 receptor antagonist. One thing that shouldn't be a consideration is requiring the patient to be on a vent, because we're actually hoping to prevent these patients from being on a vent by giving one of these agents. Matter of fact, we know from a lot of the studies, especially out of China and Italy, that if we could prevent patients from becoming from being placed on vents, that they do substantially better than individuals who have to go on a vent. Fever, that's kind of a yes/no. A lot of these patients do present with fever, but that should not also be a determinant whether you're going to give an interleukin-6 receptor antagonist. So the big things to think about whether you're going to administer these agents: is my ferritin significantly elevated? And that's going to depend on the institution, what your determination of significantly elevated is. Is my C-reactive protein significantly elevated? And do I have a significantly elevated D-dimer? Plus or minus whether my patient has a fever or not. Sarilumab is another IL-6 receptor antagonist. Same mechanism. It's going to block the IL-6 receptor. It's dosed at 200 to 400 milligrams. This is IV piggyback as opposed to, you know, what you might see looking at Clincom, Lexicom, or something like that, where they're using sub-Q. Here we're going to use IV piggyback, and this is dosed, depending on the studies that you look at 1 to 2 week interval. That's a little bit different than what Justin had in his slides, but a lot of the studies are saying to dose this at 1 to 2 week intervals. What we've typically done at Northwestern and the study that we're actually involved in, I think we're using it at, we give a dose and then 1 week later we repeat that dose. Same considerations as tocilizumab. And when you go to clinical, look at the studies that are being done with both of these agents, there are numerous studies utilizing sarilumab and tocilizumab at clinicaltrials.gov right now. Some are actively recruiting patients, some are still being planned, but there are a lot of studies looking at these two agents. Hopefully from these previous slides, you guys have a good understanding as to why that is. trying to stop this cascade from even starting. The slight difference between sarilumab and tocilizumab, sarilumab has between a 15 and 22-fold greater binding affinity to the IL-6 receptor compared to tocilizumab. Whether that's clinically relevant or not, we're going to be finding out in some of the clinical trials, but that binding is pretty impressive, and why we think that sarilumab may actually be a better overall drug compared to tocilizumab. But again, this will be determined in clinical trials. Sarilumab is more associated with neutropenias and nasopharyngitis, whereas tocilizumab is more associated with some of the upper respiratory pneumonia infections that we're seeing in some of these patients. Here are some references, and I thank you guys for allowing me to speak tonight.
Thank you, Craig. Appreciate your presentation, and we'll move right along to the next presentation with Dr. Scott Benken, Clinical Associate Professor at the University of Illinois at Chicago College of Pharmacy. He's going to discuss acute kidney injury implications of COVID-19.
Much for the opportunity to be a part of this evening. Obviously, there's a lot of press in the media and beyond in the medical community about COVID-19. I think one of the things that's very interesting, and these are all headlines that have occurred in the past week here, since Monday, just about acute kidney injury and acute renal failure surrounding COVID-19. We see things, anything from the incidence of acute kidney injury and its effect on patients, as well as shortages that surround this. We see dialysis services that are being modified and at the point of breaking. And then we also hear uplifting stories like drug companies and manufacturers coming together to address some of the concerns here. So really for this portion, we just have two things we're going to discuss. We're going to describe the multifactorial nature of acute kidney injury with COVID-19, and then we'll propose some mitigation strategies for issues that are surrounding this, and we'll talk about some of those issues. One of the interesting things about this is that we don't exactly know how prevalent or what the incidence of acute kidney injury is with COVID-19. Typically in an ICU, you can expect that about 15% of patients will develop acute kidney injury. The experience that we have, and this is largely stemming from studies that have come out of China, you see a range anywhere from 0.5 to 23% in patients that are hospitalized. One of the important things to know with sort of describing this incidence is that their studies are very small, and then they're just from one part of the world. If you focus in more on the ICU, you can see that that range maybe increases to 19 to 30% of ICU admissions. But an important thing to know is that up to 40% of patients that have acute kidney injury will require renal replacement therapy. One of the things that is very important to know when looking at these studies coming out of China is just the incidence of comorbidities. Compared to a US population, particularly of a US population of ICU patients, the relative percentage of comorbidities is smaller. So what we can anticipate in the United States when we start looking at this at a larger 1,000-foot view is that we likely will see an even greater incidence of AKI and an even greater need for renal replacement therapy in our patients. The mechanism of AKI surrounding COVID-19 is extremely complex, and it's multifactorial. As was mentioned earlier, COVID-19 contains an S protein on the outer membrane of the virus itself, and that binds to angiotensin converting enzyme 2 and is activated by transmembrane serine proteases. One important thing to know about those ACE2 as well as the serine proteases is that they are very prevalent in the proximal tubule epithelial cells of the kidney. And additionally, once the cell-cell junction of the kidney is injured because of an acute kidney injury of any variety, it allows for access of the virus into the luminal cells, which can cause more and further damage. And as Craig was mentioning, there is a massive host inflammatory response that can be seen in these patients. Those inflammatory cytokines can be very detrimental to the kidney and include everything from complement activation to triggering the B cell process, as well as direct nephrotoxicity. Additionally, if we look at these patients in the development of ARDS, ARDS is notorious for causing problems with the kidney. One of the main clinical features of ARDS is systemic hypoxemia. This is important to note because the kidneys have a high rate of oxygen consumption. They are actually second only to that of the heart, in which they rely on oxygen in order to maintain function. And so even small degrees of systemic hypoxemia can lead to detrimental effects in terms of oxygen delivery and proper consumption and utilization at the level of the kidney. Additionally, because we have a breakdown of the alveolar capillary junction, as Craig described, we have a leak of those cytokines that are in that alveolar space into the circulation, allowing for the systemic effects of them, which include going down into the kidney and finding places to deposit it there as well. Unfortunately, the treatment for ARDS is mechanical ventilation. Mechanical ventilation in and of itself can actually be problematic for the kidney. We are constantly using positive pressure ventilation when we have someone mechanically ventilated. And in ARDS specifically, we use high peak and expiratory pressure. Both of those can increase intrathoracic pressure and decrease venous return to the heart, leading to a backup congestion in the kidney. And then additionally, because there's less getting to the heart, we have a relative decrease in cardiac output, leading to the activation of the renin-aldosterone-angiotensin pathway. We get an increase in antidiuretic hormone secretion, both of which decrease glomerular perfusion pressure and decrease renal blood flow. If that's not enough, we can throw on top of these patients the idea that these patients can become septic. And with that sepsis, we are oftentimes covering for bacterial sepsis, which includes things like nephrotoxic antimicrobials. We utilize our traditional catecholamine agents for vasopressors, and then subsequently these patients get exposed to contrast periodically through contrast studies. So with all that being said, it's very well known that acute kidney injury can happen, and it is multifactorial. Interestingly, on the histopathology side of things, in postmortem findings out of China, we do see that there are these multifactorial processes. Sue and all reported a case series of 9 patients that had AKI, all of which had postmortem autopsies, and they found proximal tubule injury and frank necrosis, which could be from hypoperfusion, could be from nephrotoxic medications, but they also saw immune cell infiltration, and they also saw high levels of creatinine phosphokinase, which can lead to rhabdo. Additionally, other postmortems have confirmed this by finding macrophage infiltration in the tubules, as well as complement deposition. One of the important cases that I think, I guess, contrasts a little bit of what was seen out of China is that there was one single case patient of African ancestry that underwent an autopsy, and that patient actually had multiple and all 4 kind of the mechanisms leading to acute kidney injury. And so in our patient population in the United States, particularly in Chicago, we might see even a more multifactorial process than what is seen in the rest of the world. So an intuitive question, and I think it's probably a natural one, is what are the outcomes of these patients once they develop acute kidney injury? In the non-COVID ICU literature, we know that developing acute kidney injury increases your risk of dying. If you have stage 1 acute kidney injury by the KDIGO guidelines, you increase your risk by about 1.5 times. If it goes to stage 3 acute kidney, you increase your risk of dying by about 7 times. Additionally, we have found that the longer that you have acute kidney injury, you are more likely to develop chronic kidney disease as well as cardiovascular outcomes. And pretty interesting, if we look at the 2005 SARS experience, which it can be related to the current coronavirus pandemic, we also saw this high mortality rate in patients that had AKI. In one particular analysis, they found a 92% mortality compared to 8% for those who did not develop AKI. And unfortunately, if you look at the data coming out of China, we're seeing a lot of the same results. If you develop AKI, you develop a need for renal replacement therapy. Unfortunately, your risk of dying, even after controlling for other variables that put you at high risk for dying, is there. And so it's really important that we learn more about this disease process, more about its effects on kidney injury, and exactly how to treat them. When we turn our attention towards treating these patients, the treatment is actually pretty similar to patients with COVID as patients that don't have it. The indications to start renal replacement therapy in many instances are the same, and they would follow the mnemonic A, E, I, O, and U. A being for acidosis, E for electrolytes, I for intoxications, O for volume overload, and U for uremia. There have been multiple studies over the past decade that have looked at a delayed renal replacement therapy initiation in ICU patients, and they have found relatively safe. Now, it should be noted that that's a pretty controversial topic in non-COVID patients. Important thing is to note that these patients are different. These patients have very high levels of ARDS in many patients. ARDS management pays particularly attention to volume control and volume management. And so oftentimes we're using things like diuretic in the to try to manage volume overload. And if we can't successfully do that, we then have to quickly and swiftly move into renal replacement therapy. We also have patients that appear like they're in septic shock, and volume resuscitation is the first step of treatment for those patients. But over-aggressive volume resuscitation must be avoided in these patients. Additionally, we try to volume constrict some of these patients, but within 5 to 7 days, being at home and not feeling well and not eating and maybe having diarrhea, our own volume restriction of these patients could be leading to some pre-renal AKI. So all that being said, once a patient develops the need for renal replacement therapy in critically ill patients, continuous renal replacement therapy is the modality of choice. One of the unique aspects of using continuous renal replacement therapy that we've seen is that there's an extremely high incidence of clotting. Now, there's numerous reasons for that. One of which is, we sort of look at the data that's out there. The most common hemostatic abnormality with COVID-19 is an increase in D-dimer. And in fact, 71% of patients that die that have COVID-19 fulfill the ISTH criteria for having DIC. And we know DIC is a microvascular thrombosis or thrombogenic process. And so it's not surprising that these patients have clotting due to the mechanism of being in cytokine storm, and then that cytokine storm also leads to the release of procoagulable mediators. What this manifests oftentimes is by seeing the clotting of our CVVH filters. We also see the thrombosis of lines that are being used for dialysis. So there are a couple of ways that could be reduced. One is by using higher blood flow rate. We also can consider using a pre-dilution replacement fluid administration for hemofiltration modalities versus a post-dilution replacement fluid. And what we're doing at our center, and many centers are doing this in a variety of different ways, is considering anticoagulation. Now, that anticoagulation could either be regional or systemic. We are considering heparin infusions for our patients. If they have evidence of macrovascular thrombosis, then we're using more of that traditional PTT range of 60 to 100 seconds, or it might be slightly different from institution to institution. But if they don't have evidence of that, but they're showing some line clotting, maybe some CVVH filter clotting, we're still anticoagulating these patients, but we're doing so at more of an intermediate intensity. Now, there have been reports of using direct thrombin inhibitors, using the novel or direct oral anticoagulants, using enoxaparin preferentially over unfractionated heparin. A lot of it's anecdotal and a lot of it's still emerging in terms of the best treatment approach. But one of the things to keep in mind is that these patients, though they are in risk of clotting, oftentimes have liver involvement, which might make them at an increased risk of bleeding as well. One of the other unique complications surrounding this in the current state is this idea of rationing. We have just had so many patients that have needed renal replacement therapy that we've had to come up with ways to sort of avoid it, or at least temporarily avoid it in some patients. So the way that we've done this is we've consider fluid restriction in the right patient. Again, that has to be done with an accurate assessment of volume status, which of course is very hard because we're limiting the number of people that are actually physically examining these patients and so on. Additionally, we're being very aggressive with medical potassium management and alkali therapy as well. So we're trying to use our medications maybe a more liberal and more creative way to postpone some of the needs for renal replacement therapy. And then one of the things that we've been doing a lot recently, and particularly in the past week or so, is using this idea of like total nephron blockade, which basically is the idea of using multimodal diuretic therapy in order to augment diuresis to stave off the need for volume overload to be your indication for renal replacement therapy. One other thing is that you can actually decrease the dose of your renal replacement therapy. It's been some suggestion that you can use rates that are about half of what you would typically use, but it has to be done in the right patient. You have to consider their metabolic abnormalities and everything surrounding that as well. This can be a challenge because we do want aggressive fluid management, which requires response to be oftentimes with renal replacement therapy. And then lastly, you can consider converting your normal renal replacement therapies to other things. Prolonged intermittent renal replacement therapy, or PERT, also known as SHIFT. And there are multiple varieties of that. One of the things that we're seeing at our institution is an accelerated veno-vena hemofiltration, which is basically doing a CVVH session over 10 hours instead of the traditional 24. You can consider sustained low efficiency dialysis, or SLED, with hemofiltration, or slow continuous dialysis, or SCID. Additionally, you can do things like conventional intermittent hemodialysis with vasopressor support. And all of this becomes extremely pertinent to the pharma community because drug dosing has to be significantly considered from one modality to the next, particularly if we are switching from one to the other. The last complication to touch on is this idea of drug shortages, right? Everyone is seeing the same type of patient right now in the ICU. Everyone's using renal replacement therapy. Everyone's renal replacement therapy bags are on shortage, and they're hard to get and hard to allocate. So as you can see in this picture, this is something that I came up with, and I'm doing here with my daughter, is actually, rationing and coming up with an idea of making my own beer. Have one sitting right next to me during this presentation. And so we can actually use kind of that same homebrew type of mentality and create our own replacement fluids. And this is just one published recipe for one, but there are others out there. But our creative ways of coming up with workarounds in order to mitigate some of the shortages and to take the burden off of just trying to maintain the supplies needed for CVVH. So in summary, AKI is associated with COVID-19. We see it frequently, but we don't particularly know exactly what that looks like in the United States. It has a strong association with poor outcomes, which it also does in non-COVID-19 patients as well. And it has multifactorial causes, which require further elucidation, particularly because we can do some things, and as Craig was mentioning, and as Justin was mentioning, our first speaker, to potentially reverse some of the trajectory with this. And then lastly, the treatment of AKI with COVID, it follows convention in many cases. There does seem to be an increased risk of thrombosis. And then, being creative in terms of your machine and fluid shortages would be one of the ways, and probably the top way, to mitigate the shortages that we're seeing. That's all I have, and I just thank you again for the opportunity.
The controls away from Scott and move them to our next speaker, who is Dr. Tony Scott from the University of Chicago Medicine. He is Assistant Director of Pharmacy Operations there, and it just takes a second, Tony, I think, for you to get started. But Tony, take it away.
So good evening, everyone. Thank you for your attention and joining the virtual meeting tonight. As the Assistant Director of Pharmacy Operations at UCM, definitely had the opportunity to serve as the chair of our hospital's drug shortages task force for quite some time now. And we have definitely seen firsthand the impact that the COVID crisis has had on our ability to purchase and provide essential medications for our patients here at the hospital. And this is regardless of whether they're being treated for COVID or any other condition. I imagine that many of you in the audience as well have experienced some of the same scenarios and outcomes. So the goal of these next few slides is just to discuss the current climate around drug shortages in the US related to COVID, and to equip you all with some useful tools to manage these shortages at your respective institutions. So our departments, all of our pharmacy departments' ability to provide excellent patient care is directly impacted by the availability of essential medications. According to the FDA's definition, a drug shortage is an undefined period of time when the demand of an essential medication far outweighs the supply. It seems like it's an inexact science based on what you find on their website, but you also see later in the slides that other organizations such as ICHP have less stringent criteria and thus classify more medications as officially on the shortage list compared to the FDA. We know from our regular practices that all shortages are not created equal, and the ones that get more attention and focus are the medications that are critical to supporting high-risk patient care and also ensuring safe patient outcomes. So patient safety becomes compromised when we can't get these meds, and the cost of care starts to exponentially rise when facilities are forced to procure alternatives and, more often, expensive medication substitutes. There are some headlines included here below, but if you're following the media and news cycles closely, you'll probably seen many articles connecting the recent spike in drug shortages with the COVID outbreak. So traditionally, the reasons for why a medication becomes listed as a national shortage are limited. Many have reduced availability from wholesalers, and direct distribution channels are very narrow in terms of their options for purchasers. So the graphic shown here, published in 2018 from the University of Utah and ASHP, shows that the unknown category kind of leads the way here, accounting for over 50% of the shortages. This is primarily due to drug manufacturers not publicly disclosing the root causes for lowered supplies that are coming within their facilities. In fact, many organizations are actually pushing to make that a requirement secondary to a national shortage being announced. The other reasons highlighted here include drops in production due to manufacturing problems, medication discontinuations, and drastic swings nationwide between the supply and demand of a medication. Although I don't anticipate that the charts from 2020 will have a subsection to include a global pandemic as a source of shortages, these events will certainly get a lot of publication attention and discussion down the line. We have seen the COVID outbreak really exacerbate some of the root causes around raw material shortages and manufacturing delays specifically. Many fear that the worst is still yet to come because a large number of the raw ingredients that we see used in our drugs today are sourced from China. The circumstances created by a flood of shortages that need to be managed simultaneously require proactive planning and a fully engaged team effort. However, most organizations already had well-assembled teams put together to manage drug shortages before the COVID virus became a big disruptor. Here at UCM, we work with our task force to keep a close eye on the newest shortages coming as a result of COVID, which includes both expected medications going on shortage and also the unexpected ones as well. If you catch a shortage too late or don't have adequate plans in place to identify their impact on your organization pretty early, you might as well plan to fail because the outcomes are not going to be positive. The group of individuals responsible for managing shortages should also include all phases of the health system pharmacy department and many of the other specialties within your areas as much as possible. It's recommended to include stakeholders from other departments, such as physicians and nurses, to ensure everyone's on the same page and can implement any plans that are put into place. Please also be careful to manage the balance of necessary PAR levels at your institutions, as national organizations often report the exacerbation of shortages due to panic and excessive stockpiling by purchasing teams from facilities after the threat of a lower supply makes the news. So the list continues to grow for active and ongoing drug shortages. As mentioned earlier, the ASHP and FDA definitions kind of differ in scope. You can tell from the numbers which organization has the more lenient criteria to include a medication on the shortage list. So as of Tuesday of this week, ASHP lists about 201 active medications that are on shortage, while the FDA only lists 107 total entries. If I was a betting man, I would put my money and attention on the ASHP list to reinforce the warning of I'd rather be safe than sorry. This COVID-specific list was published in early April, and the boxed medications in red are the ones that I want to bring your attention to the most tonight, even though there are arguments to be made that pretty much all of these medications are important for critical patient care. So as Justin mentioned earlier, the hydroxychloroquine and chloroquine has gone in and out of favor for treatment regimens over the past few weeks. Albuterol and other inhalers have been on allocation for many weeks now and remain a popular point of discussion for most facilities, including here at University of Chicago. Pain meds, sedatives, and paralytics like fentanyl, dexmedetomidine, propofol, citalopram, they all have certainly caused some big headaches to manage here at our organization as well. Even routine fluids like normal saline and some of the renal replacement fluids that Scott mentioned earlier are becoming harder and harder to come by during this crisis. All right, so action planning is very important. As mentioned earlier, action planning is early and often key in managing the COVID-related shortages that we're seeing. There's lots of discussion boards and resources online, especially through ICHP, that give pharmacists tools to manage these impacted categories of medications. Hopefully you all find helpful tidbits in these recommendations that can be applied to your respective organizations if you haven't done or considered some of them already. For the antibiotics and antivirals, you should be evaluating enrollment in free drug programs as manufacturers like Teva have set up donations of oral medications through partnerships with wholesalers. There are also ample opportunities to stress IV to PO conversions to extend your supply of injectable medications as well. Our antimicrobial stewardship pharmacists here have done a really tremendous job of helping with stewardship and establishing treatment guidelines and protocols to ensure that all of the medications, including the ones on shortages, are being used per policy and appropriately. The MDIs are a huge problem for many organizations, particularly albuterol. The implementation of common canister programs is on the rise from what I've read. Recycling and cleaning canisters has led to some success stories, managing quantities on hand with the proper infection control measures in place. And organizations can also leverage the electronic health record to limit which providers can enter orders for these medications. For the meds that come in liquid form for nebulizer treatments, triaging is necessary to ensure that increased use as an alternative agent does not put providers, nurses, respiratory staff, and other healthcare providers at risk for COVID exposures from positive patients or those under investigation. The paralytics, sedatives, and analgesics probably include the largest number of impacted medications. Leaders can find published information on extended beyond use dating for compounded and repackaged formulations of some meds, which will help to reduce waste due to expiration. Increasing the max concentrations and hang times are also reliable waste reducers when it's done safely. The intermittent push doses tend to lead to less administrations of drug for select patients, which reduces overall usage, which is helpful. And infusions of these medications can lead to waste, as the bags cannot be reused once the medication is hung, usually, even if all of it is not administered to the patient. Lastly, the pressors have shown limited supplies from many wholesalers as well. I'll cover in a few slides some changes in 503A compounding regulations that will provide some relief for making drips in-house for many medications that are sold commercially currently. We have sourced products from select 503B vendors here at our facility over the past few months, but make sure you got to use due diligence to monitor their safety and good manufacturing practices to ensure patient safety. And please also take the time to evaluate therapeutic alternatives prompted in an electronic health record to shift orders towards drugs that do not have active limited availability. All right, so earlier this week, our sterile compounding manager shared some breaking news with our inpatient team that was really good to hear. As a temporary measure in response to COVID, the FDA has allowed certain medications for use in hospitalized patients to be compounded by hospital pharmacy departments. The organization does not have to change its 503A designation, which is a good thing to note. And the FDA does not intend to take action against state licensed pharmacies and federal facilities under the circumstances outlined in the guidance that they shared earlier this week. Thus, this allows compounding a drug that is essentially a copy of a commercially available drug or used in a COVID treatment, and providing a drug to a hospital without first obtaining a patient-specific medication or prescription. It does feel a bit weird to go against some of these long-standing regulations, but as they say, desperate times calls for desperate measures. The DEA has also announced on their website that they will be increasing production quotas and imports for controlled substances affected by the virus, which is good news as well. Given the extended duration of many controlled substance shortages, this gives me hope that there may be some long-term relief coming for all of us quite soon in the future. As pharmacy personnel, everyone is encouraged to advocate for important change on a large scale with federal and state-controlled healthcare organizations. GPOs are pushing for supply increases across all manufacturers producing COVID treatments and continue to push for expedited approvals of quotas mandated by the FDA. ASHP has recently published a statement calling for the current administration to release a strategic national stockpile of drugs for COVID-positive patients to any of the 50 U.S. states in need. So as you can see, there's a lot of important advocacy happening across the country, but there's still a lot of work that needs to be done to see some real changes. I know that I refer to a variety of published resources to keep a close eye on what's happening across the country regarding COVID, as changes seem to come across the various sites pretty much on a daily basis. The list of sites here have been helpful for me, and I included those here today to provide everyone listening with some resources that you can bookmark for use personally and share with your respective colleagues. Many of the updates and tips included in my content were reviewed and pulled from some of these various sources that are listed here. So with that said, definitely like to thank everyone again for their time and participation with us this evening. And it looks like Scott will be concluding the presentation tonight with his discussion on McCormick Place and some other statewide efforts put in place to help fight against the COVID pandemic.
Thank you, Tony. Appreciate the presentation. And so we'll see if we can move right along here. Unfortunately, this is my first go-to meeting webinar. So if you see some glitches, they're my fault. So let's see if we can, there we go. We're going to talk about statewide efforts and move right into it here. COVID-19 resource page on the ICHP website was established about 3 weeks ago. And as soon as information was starting to be disseminated, we placed a whole bunch of different resources, CDC website, ASHP's website, and with the idea that we didn't want to take each individual document and reproduce it, but there are some, especially the Illinois documents, that are very specific to changes that have occurred within the state. We also have a COVID-19 best practices page. It doesn't have a whole lot on it right now, but hopefully some of you that are listening will be able to share some best practices from your institution. And I think we've learned some of them tonight on this presentation. We've had discussions with the Illinois Department of Public Health and the Illinois Emergency Management Agency on medication shortages. And this conversation that occurred last Thursday created a dashboard that we've sent out to multiple, or to the pharmacy directors in the state of Illinois, both through ICHP and the Illinois Hospital Association, to get a measurement of what the actual shortages are that people are experiencing. And so far, we've had over 50 hospitals participate. Some of the big systems have participated, some of them are still missing, but we intend to keep collecting and then probably run the dashboard again in another week or so. Today we had a discussion with the FDA regarding shortages and the compounding that was taking place, or that could take place. The FDA was particularly interested in our dashboard and the data that we collected so far, so we hope to continue to share that. We've had discussions, emails, and letters that we've sent to the IDFPR staff and to the governor's office. We've asked for relief to allow retired pharmacists and retired certified technicians to reinstate their licenses without fee and without meeting the CE requirement, just like doctors, nurses, and PAs were given. Unfortunately, the department has drug their feet on that, believing that there are a lot of out-of-work pharmacists in the area that could, within the state, that could fill those needs. We did get some relief for out-of-state pharmacists and technicians to serve in remote situations or bring them into the state. Unfortunately, Wisconsin, which one of our big systems is in Illinois and Wisconsin. Wisconsin does not regulate technicians, so they are not licensed. They can't be licensed in Illinois. We asked for pharmacist administration of medications on behalf of one of our hospitals, who has said that they believe that they're going to experience a nursing shortage before they experience a pharmacist shortage, and they'd like to have the pharmacists help with med administration. We've not heard back on that one yet. However, that one did strike a chord when we had our discussion with them earlier this week. Well, again, we've talked to them, like Tony discussed, with the compounding issues and being able to compound within the pharmacy commercially available drugs that are in critical shortage. And we've also reached out to them to seek relief for hours of operation for critical access hospitals so that the pharmacist may work less in the hospital and more at home. We worked with McCormick Place initially to help them try to find the director of pharmacy. However, they found it in another manner through the Northwestern medicine system. Sean McGee-Parator is the director of the McCormick Place Alternative Care Site. He is currently also the director at Delnor Hospital, or was, and will probably go back to that eventually. We've helped identify potential pharmacy staff for them. However, their mechanism for actually bringing those folks on board are relatively unclear even to us yet. We've identified sources of needed medications for them, and we've just disseminated information on their behalf. For example, when a patient is discharged from a hospital in the Chicago area to McCormick Place, they need to carry with them 14-day supply of all their chronic medications, because McCormick Place will not carry anything but mostly PRN meds or supported meds for the coronavirus. Impact on other activities. Obviously, we've canceled the spring meeting that was in East Peoria in March. We've had to cancel Legislative Day, which was supposed to occur yesterday. We are evaluating virtual meetings for the future, and this is, again, an example of ways that we can create meetings in the future, hopefully with fewer glitches. We certainly want to consider for local affiliate meetings the same, and expanding our champion webinars. We've added GoToWebinar and GoToMeeting to our arsenal. We used to use a ReadyTalk product that is no longer available, and we are working on this. We may, in fact, have to do an annual meeting virtually in October. Life does go on, though. The Keep Posted will be out in just over a week, should reach you early May. It's set to reach you on May 1st, depends on your postman. ICHP's divisions, committees, and networks have continued to meet regularly. The ICHP search committee for a new EVP has continued to work diligently to find my replacement, and an announcement is forthcoming soon. And Pharmacy Tech Topics continues to provide outstanding CE for certified pharmacy technicians around the country. So as we wrap up here, and I think we've still got everybody unmuted, or hopefully we do, that we're speakers, I'm going to go back to the question box, and I did see two questions, both it looks like for Dr. The first one is, would you like to ask, they would like to ask if there any potential benefit in using IL-6 antagonists earlier or pre-intubation. And I think you did speak about that a little bit. Many of the ID physicians seem to believe it's beneficial to utilize it before the storm begins. Craig, what are your thoughts on that?
Thanks for the question. This has been a kind of ongoing question that we've been toying with at Northwestern a little bit, when to actually initiate these agents. And at first I was of the impression, hey, let's hold off. I've completely flipped. I've completely flipped, because these agents have really shown tremendous benefit in these patients. Their response is really rapid, and it's quite impressive when you give an IL-6 antagonist to these patients, how very rapidly they respond. So I am completely of the opposite impression than what I had a month ago. I say give these drugs early and see what happens to these patients, because they really have tremendous responses up front. So I'm of the impression if we can keep these patients from getting intubated, they do so much better than if they actually get intubated. So stop that cytokine storm up front, and they do a lot better. So early is better.
Okay, great. And another question was, is there any data to support the use of IL-6 antagonists in floor patients who have increased O2 requirements and markedly increased inflammatory markers?
This is an interesting question, because usually those patients that have significantly, and again, significant is your own institution's determination, but significantly elevated markers, those patients are usually wind up in the ICU. So given an IL-6 inhibitor on the floor, I'm not really sure if that's going to be the wise thing to do, because those patients really should be in the ICU to give these agents. Because there are some absolute adverse effects that you need to monitor for. So I would say those patients probably should be in the ICU if you're thinking of giving these agents to someone that you're worried about cytokine storm on.
Yeah, sorry, it's Justin. I was just going to hop in. I totally agree with you. Initially, in kind of our evidence review from a stewardship perspective, we even limited tocilizumab to ICU setting only in some cases. And our kind of response is totally flipped, like you said. Even yesterday or today, there was a French paper that came out, granted it's preprint, but they looked at patients about, I think it was like 30 or so patients that were treated with tocilizumab, and they showed decreased progression to the ICU as well as decreased mechanical ventilation. Again, kind of similar to that Chinese study, except there was a greater percentage of patients that were included that were non-ICU patients. So I think as time goes on, we're going to continue to see these IL-6 inhibitors and immunomodulatory agents being used earlier in the disease course. But yeah, totally agree.
Okay, and it looks like we got one more question here, and this probably will go to Tony, but anybody can comment, but I'll give the first opinion. The question is, are any hospitals extending beyond use date for rocuronium stored out of the refrigerator from 60 days to 120 days, as Europe is doing? I will tell you, I've not seen anything from the FDA that would allow that, and I know that there's been nothing from the Department of Professional Regulation. So, Tony, do you want to comment, or any of the other panelists?
Yeah, I would have to second that, Scott. I haven't seen any directions or any literature, anything that has been presented to me or us regarding doing that successfully and safely. So we haven't made any changes there. Some of our controlled substance syringes that we draw up for individual doses in our pediatric patients, we've actually found some literature to support extended beyond use dating, which has helped us to significantly reduce a lot of waste due to products expiring. But specifically for rocuronium outside of the fridge, I haven't seen anything directly that would have given us the green light to proceed with extended dating for that one. We haven't had much trouble with our rocuronium. Thankfully, we actually just switched housewide last Friday at our institution from using cisatracurium as our primary neuromuscular blocker to switching over to rocuronium for most adult and pediatric patients, and that's gone pretty good for us so far, about a week into it. So.
Yeah, I'm going to echo Tony's comments there. I've not seen any beyond use dating to what Europe has gone to, so completely echo what he just said.
Well, I'd like to thank the speakers for their contributions tonight, and thank you all for joining and participating in this update. Please share with your pharmacy colleagues that this program will be has been recorded and will be posted on the ICHP website as soon as it is reviewed and edited. There is no CE credit, unfortunately, for tonight's program, but we hope that it's provided you with some valuable information. Watch for future emails from ICHP for more COVID-19 updates, CE program opportunities, and other pharmacy-related news. And again, thank you all for participating, and good night.